Thank you, folks. Thank you for inviting me. And the weather is much better today than the last time I was here, when a lot of people couldn't actually get here because of snow. And so I think there are about 10 people, 15 people in the room. And most people were worried about snow. So what have we got here?
Thank you.
Okay, who am I? Why am I here? I'm an optometrist and I work in community practice. I'm one of those people that sit on the high street with optician above the door and sell everybody glasses. What's my interest in learning disability? Getting on for 30 years ago now, but certainly 25 years ago, in the days when people were being discharged from long-stay mental health hospitals into the community, in Bexley it was realised that we didn't really have much information about patients being discharged. For one reason or another, the psychiatrists within the large units wouldn't send both psychiatric and medical notes into the community, so everybody was sort of feeling their way. And we had an awareness that a number of people with learning disabilities also seemed to have visual impairment. Sometimes it was obvious because they had no eyes, and sometimes it was less obvious because of their behaviour. But South East Thames Regional Health Authority, Bexley London Borough and Kent Association for the Blind sponsored some research looking at the prevalence of visual impairment in a cohort of the people on the learning disability in Bexley. And at the time there were only about 350, 400 people on the learning disability register, but we found that roughly 2/3 of them had some form of visual impairment, whether that was just the need for glasses or whether it was that they had no eyes and were completely blind. Since then I've got involved with working with RNIB and then subsequently Seeability, and I'm currently a trustee of Seeability, so not only have I become involved in the information and advisory service, so providing eye care advice across the country through the Seeability service, but also as service providers I have a slight understanding of providing services for people with learning disabilities, because we've got about 20 care settings across the south and southeast and southwest, so really up to the M4 we have a number of care settings. So that's my background with learning disability. Spent some time working in the USA as well with Special Olympics, and we were looking there at the education of eye care professionals, both doctors and optometrists and ophthalmic nurses, about how to carry out eye examinations for people with learning disability. It continues to be the case that many of my colleagues and certainly many of the medics say, hey, this is just too hard, let's not bother. And families, to a certain extent, hey, it's just too hard to take my child with challenging behaviour to that care setting to have appropriate examination. I'm sure you come across that all the time with all sorts of things. And only recently in Kent, there was a lady with Down syndrome came to see me who was getting on for, well, she's about the same age as me, so mid-50s, and her mum had just died, and her sister and niece had just taken over her care, and she hadn't visited any healthcare practitioners for the last 30 odd years because there was a resistance, because the mum was told, and some of you probably know this person, the mum was probably told, this is just too hard, or let's write your daughter off, and was so challenged 30 odd years ago by the healthcare system that she'd never had any support. And this lady had dense cataracts and was struggling to manage, and was eating inappropriate things because she couldn't even see the food on her plate. And it was that type of intervention that still goes overlooked, and it is overlooked. So that's the purpose of today, is to really say, don't forget people's eyes. And just to say that, you know, we're not beating our own drum in the eye care sector. This O'Hara and Sperlinger are psychologists, and they wrote that vision testing should precede any assessment of mental ability. And that kind of makes sense, because if you're trying to do an IQ test or assess somebody's functional ability or their ability to communicate, if they can't see, how can they see what you're asking them to do? How can they see the test that you're asking them to do? And is the reason that they can't perform the task because they've got a learning disability, or they have some sort of inability to move their limbs, or is it actually they can't see the object that you're asking them to point at, to look at, or they don't even see the command that you're trying to give, whether that's through sign language or the spoken word? And then obviously you know about the other sensory problems. 40% of people with learning disabilities are going to have a hearing impairment as well. So we've got this risk of dual sensory loss of deaf blindness. So sight is really important. I don't know, I mean, a number of you are wearing specs. When you take your specs off, you realise the world's a bit blurred. And if you think about how difficult it is to interact with the modern world if you can't see, and even more difficult if those around you who are trying to interact with you don't realise that you can't see. And most daily tasks are more difficult if you can't see, and you should try this out. You should just make yourself up some simulation spectacles and just blur your vision. Get yourself some safety specs, cost £2 from B&Q or somewhere. Stick some sellotape, about 10 layers of sellotape on them, and that simulates pretty well dense cataracts. And then go and make yourself a piece of toast, make yourself a cup of tea, do various tasks around the house and see how difficult it is. But when you're doing it, don't do that and then have a sneaky look, because the person with cataract can't do that and have a sneaky look. They've got to be able to carry on like that, potentially for the rest of their lives. And sorry, do you want to come in?
I'm sorry.
It's too warm to stand. And they've got to carry on for the rest of their lives like that. And what you've got to realise is when you're attending best interest meetings to decide should this person go ahead and have surgery, if you say no, or if you decide that there is inadequate support to support that person through their post-operative period, or the surgeon is being a bit awkward and saying, well, maybe we shouldn't do it, you've got to be that person's advocate, and you've got to say, well, I don't want to be that person with blurred vision for the rest of my life. So you have to advocate for these people. And what we all tend to assume, if you sit on a bus, or I'm standing here, I'm looking around the room, and I'm assuming that you can all see. And I'm giving this lecture, and I lecture to visually impaired people quite often, and I fall flat on my face because you come up with a PowerPoint and they also can't see the slides. So they have to do audio description. And I'm making the assumption that you can all see my slides. And I'm a trained professional in eye care, and so it's natural that everybody else will make those same assumptions, that the person that you're dealing with can see, hear, feel the same way as you do. And what we've got to remember is both through sensory processing and other reasons, those people may not interact with their world in the same way. So, important facts. People with learning disabilities are 10 times more likely than the average person to have visual impairment. And the reason for that is the brain and sensory perception through sight takes up an awful lot of processing power in the brain. And a lot of the conditions that cause learning disabilities affect the visual pathways or the higher visual centres or the way that we interpret the world. It may not be the ability to see an object, but it may be the ability to see a moving object, or to see colour, or perceive objects on one side versus the other side. So there's a whole lot more to vision than just seeing an object. It's interpreting what it is. If I say to you the word fox, you've got a vision of this red furry creature with 4 legs and a bushy tail that probably nicks your chickens, or you might think it's a nice cuddly creature that stands on top of a mint. But you'll all have this vision of a fox, and you've gone through that visual processing of your visual memory thinking about what a fox looks like. And you've got to remember that some people with a learning disability may not be able to think and visualise and perceive things in quite the same way. Just as if you use a picture instead of an object, seeing the picture of a fork is not the same as actually seeing a fork, because the two are different. And if you get really literal about it, and if you ask somebody to match, they might say, well, they're not the same. So if somebody's autistic, they might say, Well, actually, that's a picture of a fork and that's a real fork. Of course they're not the same. No, you can't match those. So think about it more widely. 60% of people will need specs. Now, quite a lot of people who are over 40 need specs anyway, because you need specs for reading. But quite significant numbers of children and young people with learning disabilities also have a need for spectacles. And the cry that we hear all the time is, oh, well, they won't wear them anyway, what's the point of coming to the opticians? But most people who have a significant need for spectacles will wear them. And one of the anecdotes I give here is a young man who I saw at Nash College in Bromley, so tertiary college in Bromley. He was 22 and he had been at Great Ormond Street when he was a child. He had multiple disabilities, been at Great Ormond Street, and way back in his notes, when we went through his notes, it said, this child can see things at roughly 10 centimetres. Well, that meant to me, he was highly myopic. He was about -10, so that's bottom glasses, bottom of Coke bottles. He could see things here. Everybody had forgotten that. He had never been prescribed specs. It was found at the hospital that he had that, but nobody had gone ahead and got him some glasses. Been in the care system all his life. Speech and language therapists have been working with him, occupational therapists working with him, physiotherapists working with him. Because he was right down on his bliss board about this far away, sitting in a wheelchair. And nobody could raise his head. Everybody was thinking he must have scoliosis, curvature of the spine, got other problems. Got down on your knees, tested his eyes, found that he was -10, went to deliver his glasses, and it makes me cry now, went to deliver his glasses in the gym. He was working with a physiotherapist on a beanbag, trying to straighten him up, trying to get him to do things. We put these glasses on, and suddenly he raised his head and just looked around. And the physiotherapist just burst into tears and said, I've been trying to do that for ages, and it was just that he couldn't see anything further away than this. So to be able to see across the room was enlightening for him. So that's the sort of thing, the difference that you can make with a simple pair of specs. Significant number of people meet the criteria for visual impairment. So that's kind of less than 660. Those of you that had your eyes tested on the condition chart, or if you go to a hospital unit, that big letter on the top of the chart, if you can't see that when you're standing 3 metres away, so half the normal distance, is the standard for visual impairment. When it comes, and that's for serious sight impairment, what we call SSI these days, or blind, and partial sight is when you can't see it at 6 metres. And even more people fail to meet the World Health Organization criterion, which is roughly the number plate standard. So being able to see a number plate at 20 metres is the World Health Organization. They say if you fall below that, whether it's for specs or whether it's because it's an uncorrectable visual error, that would mean that you are visually impaired. And again, think about that. Blur your vision to that extent with a bit of sellotape or a bit of Vaseline on a pair of glasses, and then see what it's like to cross a road. How can you judge the speed of traffic? Can you find something at low contrast? Do you trip over concrete steps? Those sorts of things. And the worse your learning disability, the worse your visual impairment's likely to be. And that kind of makes sense because more of your brain is more likely to be damaged. But this is the new findings, both we work with Cardiff University, and they've done a big study of special schools in Wales. They've had an easy task because there's only 48 special schools in Wales. In England, we're now mirroring that research because the Department of Health said to us, well, English children are different to Welsh children. We're not going to have the same results if we do it in England. So Seeability is sponsoring some work called the Children in Focus campaign. And we are delivering sight tests in special schools. And we're finding that kids in special schools are 28 times more likely to have a visual impairment. And in the second year results so far, we're finding that of the children who've never had a sight test, 3/4 of them have got autism. And we think the reasons that they're not having sight tests is because, hey, it's just too hard to get this child to go to somewhere that's awkward. And if we're delivering the sight test in a special school, that's where they go every day. It kind of normalises their life, and it's not going to see a scary beardy man in a shop where they don't expect to be grilled and locked in a dark room with me. So it's easier to deliver it there. And so these are the results, and of the 6% that had, only 6% in, this was Wales, had visual problems in their statement of special educational needs, but almost 40% of the kids have never had a sight test. 20% were found to have a visual impairment likely to impact on their ability to learn, and half of the pupils needed spectacles and only about 30% had them. So significant, simple problems, simple correctable problems were found. That was in the studies of in Wales. And then again, our Children in Focus campaign, we found around 40% no history of a sight test. Now, if we look at mainstream school, all children rising 5 should have vision screening by the nursing team, which is orthoptist led, so led by somebody from hospital setting normally. Usually it's school nurses that deliver the sight test, and at 4.5, 5, all kids should get their sight tested. Across the country, it's only about 2/3 of local authorities deliver that, but that's what should happen. But in special schools, that doesn't happen. And that's something that we've been very concerned about. And then kids seen in hospital, they're followed up by the ophthalmologist, and then around about the age of 6 or 7, the ophthalmologist thinks, well, may as well discharge them. And so they discharge them into the community, which is what would happen with a typical child. But if you've got a learning disability, where do you go from there? Where do you get your next pair of glasses from? How does, if you're in a multiple disability setting, are you going to get follow-up? Will you get adequate domiciliary optometric cover? You can. The quality is mixed, so there's some issues there. So, some questions for you guys. Hands up, who knows the visual status of all their service users? You can hand on heart say, in their care plan, I know that they can see or can't see. So, that's the challenge for you. And that was our challenge, or my challenge, and a chap called Paul Ursel, because we both joined Seeability as trustees at the same time, and we thought, okay, this was the Royal School for the Blind. Of course they'll be testing everybody's eyes. And we found that about 2/3 of the people accessing Seeability services were having regular sight tests, and that meant 1/3 of them weren't. So we've now put into people's care plans, and one of the what do they call it? KPIs, key performance indicators, that we as trustees look at from all the services, and we ask the registered managers to make sure that this happens, is that people have got to have a sight test every 2 years. And we're now reaching about 98% success on that, on residential services. On day services, it's much more difficult because people don't necessarily do as they're told, and even if you ask parents and carers to take people to sight tests, doesn't necessarily happen, so we're falling a bit short there, but that's something that you should think about. And how does that undetected visual impairment affect people's safety, health and well-being, and are your resources being allocated adequately? If you don't know that somebody can't see properly, you may be delivering more hours of support than that individual actually needs. Because if that person could see to get from the bathroom to their bedroom on their own, then you, in the space of a week, and if you save an hour a week of support package for an individual, the cost savings and the hassle factor of getting their vision looked at is paid for over and over again, and you empower the individual. And that's the point I make there. And that poor chap on the right, the term mocking the afflicted came from the asylums in London, and that was how people with learning disability used to be treated, with a stout ring around their neck that they could stand up and sit down, and it used to be considered acceptable behaviour of the gentry to go along to the asylums and actually mock the afflicted, so points, and so that was the Bethlehem Asylum in London that was taken. So what are the drivers for change? I'm not going to really rehearse these, but some of you will know about valuing people now. Death by indifference, the 6 Lives report, where 6 people with learning disabilities died because of effectively diagnostic overshadowing, so some assumptions were made about their condition, saying that it was their learning disability that was causing the problem rather than the fact that they had cancer or they had other problems. And that led to Healthcare for All, and we've got Human Rights Act and all these other things going on, and we've now got the DES for GPs, so people with learning disability should have an annual health check. GPs get paid for that, and part of that is to say, yeah, I know about this person's visual status, but as you guys have just said, you don't know about their visual status, and the GPs don't look after them, you do. So it's really exchange of information is the next thing that's got to come from that, and people should actually get to know who's got a problem. And it's really doing the right thing. And one of the things I always think about here, and part of my work with Special Olympics was looking at the history of care for people with learning disabilities. And we in this country are probably, we like to feel we're quite enlightened now. But if you go back 30 years, it's only in the 1970s that all children were considered to be educable. Prior to that, you could just lock them in a hospital and not deliver any service to them other than keeping them alive. And so it's not really that long ago that we were in the same position as some of the countries that we now look at, and we frown and we say, oh, Romanian hospitals where they just stick kids in rooms in cots and abandon them effectively. How terrible is that? We used to do that as well. And some of the people that I met those many years ago, and the older ones amongst you will recognise this, who were in the long stay hospitals, were very well cared for, but actually didn't have any stimulus at all. And rocking behaviours and self-stimulatory behaviour was really quite common. So those are the sorts of things that we have to avoid. Okay, on to eyeballs. How many of you have done something about eyeballs in biology or during your nursing training or whatever? Okay, so we've all done a bit about eyeballs, good. Development of the eye. The eye starts to develop pretty early on, so from 6 to 8 weeks gestation you can start to see on the embryo that's forming the lens plateau, the surface of the eye, and that little tadpole starts to get thickened bits on the outside of the skin, and those then fold inwards and form the lens of our eye. And because they're forming the lens of our eye, they're there from way before we're born, and they're there until you have a cataract operation. And the same lens is there, and it's dividing and growing throughout life. And that's why when we reach about 40, it gets a bit too big, and it loses its flexibility, and you start to need reading glasses. And when it gets to about 70, it starts to form a cataract, unless you insult it along the way. And if you give it a bit of a kick with listeria, or if you give it a kick with a bit of rubella when the baby's in the embryonic stage, you can cause a cataract. So you can cause that abnormality in the development of the eye. So all the developmental phases during the embryonic growth and right up to 40 weeks gestation, the eye is developing. So 40 weeks gestation. So how many of you deal with people who were prem babies? Everybody put your hand up. Right. So the increased survival of low birth weight babies is again on its own causing visual problems, because people are more likely to have problems with the blood supply to their retina and have what we call retinopathy of prematurity. It was a big, big problem back in the 60s, because you used to take a prem baby, stick it in a high oxygen concentration, blood vessels grew in an abnormal fashion, the lungs developed better, but actually the eyeballs and other bits didn't. So we understood then that we needed to be better at titrating the dose of oxygen and looking out for ROP, retinopathy of prematurity, and it got a bit better. But people who were born back in the 60s as prem babies who are now in your care may have visual problems stemming from their early treatment. So then in the 70s and 80s we got a bit better, but also what was happening was smaller and smaller babies were starting to survive, down to 23 weeks gestation, and only a few hundred grams at birth, are now surviving, and many of them will have learning disabilities because it bleeds on the brain, but they'll also have visual developmental problems as well. And if there's anything that affects mum, it generally affects the developing baby as well. So some of the things, what you should look for is an eye that looks like this. Generally a nice shiny eye. Look at your own eyes in the mirror occasionally and say to yourself, oh yeah, my eyes are shiny. They're white, unless you've had a heavy night the night before. The eyelids are generally not too flaky and crusty. You generally don't have gunge all around your eyes, and your eyes don't have a pussy discharge every morning. So why should anybody in your care or those that you advise have eyes that look anything other than like that? And if they look anything other than like that, find out why. So people with Down syndrome, for instance, have way more blepharitis, way more inflammatory problems with their eyelids. And if that's not treated, it can cause secondary infections on the front of the eye. It can cause the eyelids to start turning inwards. And if you can imagine what it feels like to have your eyelid turned inwards and your eyelashes scratching up and down on the front of your eye, it's really uncomfortable. And that's quite common in people with learning disabilities, because if it happens to you, you know about it. If it happens and you can't tell anybody about it, it can cause a problem. So if you see somebody with a red eye, sore eye, constantly gungy eye, try and find out what's wrong with it. These sorts of developmental problems, that's a thing called the collarbona of the iris up on that side, and that's where the eye has failed to close. So a bit like spina bifida, but it's affecting the eye, and it's incomplete closure of the embryonic tube. And the one at the bottom is the blepharitis, where you get this sort of crustiness on the lids and the lashes.
So sorry, what problems would that cause then?
The blepharitis, long term with blepharitis, what happens is, because you've got constant inflammation of the eyelid, and the eyelid is really the windscreen wiper for the front of the eye. So skin goes up your face and it's normal keratinized dead skin on the front, and then halfway across your eyelid it's a nice square edge, and that turns into mucous membrane, and that nice square edge acts as the windscreen wiper and replenishes your tear film. So anything that interferes or causes inflammation of your lid margin will affect how well you see, and it makes your eyes to blink more, and it makes your eyes dry and uncomfortable. And then if you leave it and don't treat it and don't manage that properly, it will cause secondary scarring, and then it tends to cause the eyelid to turn in, or the eyelids to become droopy. And we've all seen Grandad who's got droopy eyelids, it looks like a bloodhound, and he's probably got secondary dry eyes and secondary problems because of that. So just simple use of ocular lubricants, dry eye drops and that sort of thing can make life more comfortable for these people. The way that the eye forms, the way an eyeball works is, we've all cracked an egg. On the inside of the eggshell you've got that thin skin, and that thin skin is like the retina. So the retina is the light sensitive film that sends the message to the brain. In front of the retina you've got a big lump of jelly, a bit like the white of an egg, and right at the front of the eye you've got this lens that I was talking about earlier. And then the eyeballs are connected via the optic nerve, and the optic nerve's interesting because everything I see on this side of me goes to the left hand side of the brain, everything I see on this side goes to the other side, so they cross over just about an inch behind the bridge of your nose, and the visual pathway goes around to the back of your brain. So anything affecting that, the structure, if somebody's got facial problems, if they've got problems with the orbit, if they had a droopy lid when they were a child, if they've developed a squint, they can have problems with their vision. And the visual pathway means that because it's using all of this bit of brain, any defect, any injury to the brain, which is really the definition of a learning disability, is an injury to the brain in early life or a lack of development, will or may cause problems with vision. And what we've also got to look at is how vision normally develops. Now we all hear in the press, this child has a mental age of, or this person has a mental age, and it's frowned upon now. World Health Organisation still use it a bit, but we all frown upon that. But when we think about visual development, what happens when we're born, our vision is we can see the big letter on the top of the chart. Back in Victorian days, we used to think children were born blind, because that was because you put a Victorian baby in front of a test chart and you'd say read the letters, and it couldn't, so you said it was blind, because the test was inappropriate for the age. So now we use different methods of testing, attach electrodes and things, but we still know that the visual pathway hasn't fully developed. So if there's an insult, if the person has cerebral palsy, then that vision may never develop to be beyond that standard. And it's only at about 3 years old that the typically developing child reaches adult levels of visual maturity and can see as well. So if I'm seeing a 2-year-old, I don't expect them to see as well. And if I see somebody with Down syndrome, if they can see half as well as the typical person, I think they're doing pretty well. So that's how acuity develops. But what we've also got to think about is this, and those of you that want to do a bit more reading around this, if you look at either books by Gordon Dutton or go on the website onto the internet, and if you look at, there's an old lecture that he gave, I think it was 2002, called the Edridge Green Lecture, and that gives a description of how the higher centres and the executive processing of, you see an object, how do you interpret what it is? How do you move through visual space? Because if you think about it, you run across a car park, you scamper up the steps and you catch the bus. Yeah? How many of you actually think, that step's 4.5 inches high, I've got to lift my foot that much just to put it down and then do that? We all move through visual space, we don't think about it at all. And the way that works is not through seeing things, thinking how big they are, it's actually through our pupillomotor pathways, which go to our midbrain and then go up to our parietal cortex here and then to our motor cortex. So it's like reflexes. If you go to somebody, like that, they blink, they don't think, oh, what's that coming towards me? You think about that afterwards, or you're walking through a wood, or some of you that wear specs will walk into a dark room and you'll think, oh, what's that? Particularly if you've got new glasses on, because the frame's in a different position. So that just happens as reflex. That protects us from the world and allows us to walk through visual space. So many of you will have clients who, do you call them clients or patients? Clients. Many of you will have clients who will walk along, slightly shuffling gait, they'll come to a change in colour in the carpet and they'll take a big step over it. Or they'll have real problems descending the stairs. They'll be okay going up, but have real problems going down. Or if you ask them to take an object, they'll be able to pick up the object, select the object. If it's 2 objects on the table and you say pick up the bottle of water, they can do that. If you stick the bottle of water in a bag of shopping, they haven't got a chance, can't do it. Or if you take that individual into a supermarket where suddenly you've got lots of people moving around, you've got lots of bright things, lights, noise, they suddenly close down or have a bit of a tantrum, and that's because they've got sensory overload and they can't function, their vision's not working properly. You'll come across clients who are very happy watching slow-moving cartoons, but as soon as an action movie comes on, they'll close their eyes and lose interest, don't like it. And it's these higher centres and what we call cerebral visual impairment or cortical visual impairment that could be playing a part in those behaviours. And that's really just how sort of executive pathways of how vision works. And really it's way too complicated to worry about, but it's just when I talk to optometrists, even optometrists and eye doctors only really know about the top grey bits, and they forget about all these other brown bits down the bottom, about all this higher centre functioning and how we actually truly interpret our visual world. So, lots of stuff affects people with learning disabilities. Keratoconus. Keratoconus, I haven't highlighted it here. Keratoconus is a condition that affects the cornea. Prevalent, depends which study you look at, between 4 and 20% of people with Down syndrome will develop keratoconus. And keratoconus traditionally was treated with initially hard contact lenses, and then big hard contact lenses, and then a penetrating corneal graft. So you take the cornea of a dead person and sew it onto the cornea of the living person. Some of you will have people who've had those procedures done. Think of the complexity of trying to get somebody with a learning disability to manage a pair of contact lenses, or the care teams with whom you're working to teach enough people how to manage that person's contact lenses for them. So that's a massive problem. So one of our areas of interest at the moment, me and some workers at Cardiff, is how do we detect keratoconus early? Because there's a new treatment for it called collagen cross-linking. And if we detect people with keratoconus early, we can treat them with a one-off treatment that will probably prevent them from needing other intervention later in life.
How early are you thinking?
We're thinking about, it tends to develop in teens and early 20s, and it tends to be progressive. So it's important, particularly with people with Down syndrome, to have their eyes examined regularly from around, well, all their whole life really, but from 10 years old onwards, and particularly if their vision's getting worse. Depends on how good they are as a witness in terms of telling you whether their vision's getting worse. If they're not a good witness, there's objective ways, but it's worth asking the question of the person doing the examination: have they got keratoconus? Is there any risk? And if their spectacle prescription is getting stronger and stronger, particularly if the SIL component, the astigmatism, is getting stronger and stronger, you should ask the question: are they developing keratoconus? Because they've got, the reason we think it happens is because of collagen structure deficits that affect both the heart and the eye and various other things in people with Down syndrome. So they're more at risk of developing keratoconus. But the reason that we want to catch them early is because we can do something about it. CVI I've spoken about. And how many of you got patients with periventricular leukomalacia? I just like the word. It's really nice word. So PVL is something that affects many, many prem babies and many people with cerebral palsy. So if somebody has a bleed on the brain or hydrocephalus, and the ventricles in the brain, the fluid-filled spaces in the brain, expand, and they cause damage to the brain around that. So periventricular means around the ventricle, and leukomalacia means damage. Mal means bad, so leukomalacia means damage to the white tissue surrounding the ventricles. So it's just a long word that the medics use. PVL is what everybody actually calls it. Why are we interested in it? Well, people with PVL will have damage to the visual pathway, because the visual pathway, if we go back a couple of slides, goes very close to the ventricles, and as that person gets older, the appearance of the optic nerve starts to develop optic atrophy, but often you don't see that in the child. So you take the child along to the ophthalmologist or the optometrist, and we say the eyes look okay, but why is this child not visually normal? And then when they become older, you say, those optic nerves look really abnormal. But if, as with many of the young kids these days, you have access to brain scans, you can say, there was some brain damage, it's likely that that's impacting upon vision. So think, if you've got somebody with a vision impairment, how much history do you know? How much access? And if they're 60, you won't have any. I've yet to come across somebody where we've got a good note. But if you've got somebody who's 10, who's been under Great Ormond Street or one of the big children's hospitals, they'll have had scans, they'll have had all sorts of stuff done. And it's worth just digging through the notes, seeing if there's an underlying possibility that could be causing their visual impairment, if you suspect it. Because then when you go to the eye doctor, you can say, oh, this person was a prem baby, they had XYZ, when they had an MRI scan, they had some periventricular leukomalacia, how about it, doc, what do you reckon? And they'll say, oh, that's really good, yeah, thanks. I agree with you entirely. And it just makes everybody's life much easier. And so that's an optic nerve with what we call optic atrophy down there at the bottom, so it looks pale, looks white. And that's the sort of thing that we look out for. But if they both look like that, both nerves are the same, it's harder to detect. And if you've got somebody that's wriggly and really doesn't want to let you have a look for very long, it's quite hard to see. And so I used to think, people aren't doing their job properly. But even some of the best eye doctors I know have missed stuff in wriggly 2-year-olds. And you can't blame them, because it might be that that person was having a bad day. And likewise, somebody with a learning disability often will go, I'm not going to let you have a look in my eyes at all. And so you've got to think and be non-judgmental about it. So that's the data on that. So can eye examinations be done? Yes, they can. How many optometrists will do them? One of the problems with optometry in the high street is the way that it's funded. And the way that optometrists are funded in the high street is there's a thing called general ophthalmic services, where an optometrist is paid a flat rate of £20 and a bit to do an eye examination. They are only allowed to claim that money if they've done a certain number of tests, and they can't claim the money until all of those bits of tests are completed. Now, if you have somebody with a learning disability that attends and decides that they don't want to go into the room, it's lost time, and the next time they come, they still don't want to go into the room, or they'll only do half the test and you get it back another time. So that person could spend, and I often do, spend several days, hours, testing that person on multiple occasions. I'll still only get 20 quid for it, unless I work in Bexley, because we've negotiated a higher fee. And that's what we're trying to push for nationally, because it's unfair access for people with learning disability that practitioners only get the same amount of money. So some of the resistance you may face can be due to financial. Some of it can be because patients are booked in at 20-minute slots in a high volume, busy practice, and hey, you turn up with a multiply disabled person in a wheelchair and no verbal communication, and the person thinks, oh God, this is going to be hard work. And so it doesn't fit with their normal day job. So it's worth letting them know that that's going to happen in advance. And it can sometimes be because, God, I've never done this before. I don't know how to deal with somebody with no verbal communication. And that's okay too. And I think when I talk to professionals, it's reassuring professionals that actually sometimes it's hard. You guys deal with people with learning disability all the time. The person in the high street doesn't. And you'll sometimes get a bit of resistance. What's the law around it? Well, we've got Disability Discrimination Act, we've got laws as far as general ophthalmic services go that means that you can't refuse to see a patient, but you may find that you can't see a patient appropriately. But my view is you nearly always can, but you have to make sometimes more than reasonable adjustments, but you should make reasonable adjustments to see those individuals. And that's what we're working on nationally to try and get that recognised. And I was just talking up in Manchester to the 9 CCGs in Manchester who have all decided that they're going to pay Optom more to do the eye examination for people with learning disability, but to provide you guys with a report on the visual status. So when I ask the question next time, what's the visual status, you'll be able to say, oh, we all know. Because if you had it written down and it went into that person's care records, it would make life a heck of a lot easier. This is something that you can do. So on the Seeability website, there's a thing called Functional Vision Assessment. And because you don't know the visual status of all your people that you look after, you don't have to do it yourselves, because I'm sure your caseload's pretty heavy with learning disability nurses. But you've got care staff working for you with those clients, you've got key workers working with those clients, and you should be asking the key worker, what's the person's visual status? Have we got any concerns about their visual status? And this gives you a checklist that can be done over a period of a few days or a couple of weeks, and you can actually see whether that person's visually functioning normally or not. And then you can tick the box and say, actually we're okay, routine, every couple of years we'll take them on to the optician just to get their eyes checked, or hey, I found something that I really didn't know about. And anecdote here, I went into a care setting to carry out an eye examination for a lady, and she would never drink at meal times. And they didn't know why she would never drink at meal times. Well, I looked at her and thought, I know why she doesn't drink at meal times, because she was hemiplegic and she had cerebral palsy, and she had right-sided paresis. Now, something that goes along with that is what we call hemianopia, which is you can't see anything on the right-hand side as well. Where's the drink? On the right-hand side of her plate. She'd leave food on the right-hand side of her plate, and she would never drink because she couldn't see the cup. They moved the cup over to the other side, and that person is now empowered to use her left hand, which is her good hand, to pick up a drink and have a drink at lunchtime. And that just makes it so easy, and it's so obvious, and that's the sort of thing that you can pick up with this functional vision assessment.
Can I just ask, why are optometrists not pushing that? Because I see a lot of people in annual health checks in Planet, and they're not aware of any of these things. And I do push it, I do say, look, if you're aware of this, you should take this to your optometrist, but why are they not doing that to people's attention?
Because they don't know either. So I'm a bit old really, but I've got an interest in something that doesn't make money. And if you think about the commercial pressures of running a business on the high street, many people they're altruistic and they want to help, but if they've never been told about it, of all the universities in the country, there's only in Cardiff where the optometry students get access to seeing people with learning disabilities, and that's only because of the expertise of a colleague of mine called Maggie Woodhouse, who is actually doing a longitudinal study on a cohort of children with Down syndrome. So she's got about 200 odd children with Down syndrome now who she's followed, and this is why we're finding out so much information about Down syndrome. And one of the PhD students has just done some work on cornea, and we've actually got mice with Down syndrome. So working with one of the mouse specialists at Queen Square, she actually has developed a strain of Down syndrome mice, which has meant that we can start doing more studies on those sorts of things. So how do you test somebody's vision? Functional vision assessment is one thing. Everybody else says, can't take them to the optician because they can't read their letters. Got no verbal communication. How are we going to do it? Well, we can use a thing called the Cardiff Acuity Test. It was designed by Maggie Woodhouse at Cardiff for babies, and it takes the form of a preferential looking test. And basically, if you give somebody something really boring and something interesting to look at, they'll look at the interesting thing. And that's from about 3 months on. So with babies, we use stripy bit, plain grey circle, they'll look at the stripy circle. You just watch the way their eyes move, and then you make the resolution task more difficult. And the nice thing about the Cardiff cards, people can sign, so they can say fish, or they can say bird, or they can say whatever, cup, and so they can sign for it, they can look at it, you can use it as a point at where it is, show me where the fish is. Doesn't matter if you tell them what it is, you can ask them to then point, and so you can use it for many people with learning disabilities. The next level up would be using pictures and picture matching instead of letter matching, because people are often more familiar. You get a bit of kickback from some people saying, well, it's not age appropriate to use pictures, and it's really offering the individual the highest level test that they're comfortable with, and ultimately you'll go to letters. But again, in Cornwall, we were working with speech and language therapists down there, and she said, I took her home, and here we are, we're in England, and everybody's drinking coffee. Why is that? Because they were saying, do you want a cup of tea or coffee? And I remember the last thing that had been said to them, and they were all saying coffee. So she introduced forced choice preferential looking, so she had a picture of a cup of tea and PG Tips next to it, and she had a picture of coffee and Maxwell House next to that, and she would then say to people, which one would you like to drink? And we've now got 70% of people in those care homes where she works drinking tea, which is about kind of average for the UK. So you've got to think about the way that you ask the test and the way that you perform these tests. And then we can do letter matching, you're showing which one's the same, and those sorts of things. We can look inside people's eyes and we see all sorts of things. This is somebody with neurofibromatosis, and they've got a retinal, what's called a retinal astrocytoma, so they've got a tumour in their eye. And these people, they've developed lots of tumours in their brain as well. But we can use novel tests like taking photographs, particularly if you're dealing with somebody with autism. If I'm going, invading your personal space, getting really close and looking in your eye like that, hey, it's a bit scary. But if I ask you to look into a machine, it's often more comfortable. And so you need to use different ways of examining people. Retinoscopy, how do I know with somebody who has no verbal communication how strong their glasses are? Well, I can get a pretty good idea without asking any of you what strength your glasses are with a little thing called a retinoscope. And just waving that at your eyes, I can tell how strong your glasses need to be. And so if I'm working in an eye camp in Africa where I've got no verbal skills and I can't communicate with individuals, we can test their eyes and give them the right glasses. That's how we do it with babies, and that's how we do it with people with learning disabilities. So you don't have to be able to talk to me for me to know how strong your glasses need to be. So, and it works on, you know, the red eye reflex that you get when you take a flash photograph. As the light goes into your eye, if your eyes are focused normally, it'll come out in a certain direction, and we put lenses in front and adjust that power, the exiting light, until we've got it what we call neutralised, which is basically coming out parallel and focused on distance. We just adjust the focus. So using retinoscopy, we can test people's eyes. Sometimes we need to put drops in to do that, to relax the focusing power of the eye, but not all the time. And I don't think it works very well. First time I meet somebody with a learning disability, hey, my name's Gordon, I'm going to put these nasty stinging drops in your eye, bang, ooh! You know, it doesn't, they don't come back again. So we tend to avoid those on the first occasion. So subjective testing, we can do that as well. You tend to show bigger changes. Some people can do that really, really well. Some people can't. Some people with PhDs are a pain when you're doing this, because they'll say, well, the first lens, things are a little bit rounder, but there's a little pointy bit on that side. And all I'm saying is it clearer first or second? I don't want a description of what you're seeing. So it's not necessarily people with learning disability where it's difficult to test their eyes. So what do you need to do? Functional assessment of everybody that you see.